will start now. Good evening and welcome to yet another COVID-19 Conversations. As usual, I am your co-host, Dr. Maya Williams, and asking the questions tonight is Dr. Alison Myers. Our latest COVID-19 statistics, thus far, we have over 40 million COVID-19 cases in the United States. Our 7-day case rate per 100,000 COVID-19 deaths. Our latest COVID, thus far, 65% of the population have received at least one dose, and 53.2% of the population is fully vaccinated, which means that 176.7 million in the United States are fully vaccinated. Recently, the FDA amended the emergency use authorizations for both the Pfizer and Moderna vaccines to allow for the use of an additional dose in certain immunocompromised individuals, specifically solid organ transplant recipients or those who are diagnosed with conditions that are considered to have an equivalent level of immunocompromise. And since that has been implemented as of August 1st, 2021, we have over 1.44 million people who have received the additional dose. And this is why we're here tonight to talk about organ transplantation. And so just to give you some brief statistics about organ transplantation, thus far we have 106,840 is the number of men, women, and children on the national transplantation list. 17 people die each day waiting for an organ transplant, and every donor can save 8 lives and enhance over 75 more, and you can definitely help. 49,000 transplants were performed in 2020. And every 9 minutes, another person is added to the transplant waiting list. So here we could see a graph of the number of transplant people on the waiting list versus the transplants performed. And we could see that kidney is the most common transplants needed. And the number of transplants needed versus the number of transplants which is received is actually, there's a disproportionate number. And so what is the impact of COVID-19 on organ transplantation? We have 51.1% reduction in deceased donor transplantation. 71% of centers place complete suspension of the live donor kidney transplant. 84% of transplant centers added restrictions. But the good news is that by mid-May, transplants performed reached pre-pandemic levels. And as we have seen in this show, we have racial and ethnic disparities. So it doesn't matter at the end of the day, the transplants can be successful regardless of the ethnicity of the donor and the recipient. However, the chance of long-term survival may be greater if the donor and the recipient are closely matched in terms of their shared genetic background. So as I mentioned earlier, over 100,000 people are waiting for living organ transplantations, but nearly 60% of the national transplant waiting list are from multicultural communities. And that is 29% are Black or African American, 20% Hispanic, 9% Asian, 1% Native American, and 2% of multicultural descent. And as we could see from the graph here is that there are 40% of white people are waiting for transplant lists, but there are 54% of the total number of organ transplant recipients as of 2020. On the US transplant waiting list as of 2020, 29% were Black, 20% Hispanic, 9% Asian. But what we find happening is that there were 22% Black, 17% Hispanic, and 6% actually were the organ recipients as of 2020. Also, while 13.4% of the US population is Black, at least 35% of those on dialysis for kidney failure are actually 45% of them are Black. And so here we have a story of disparities in renal transplant. And this is a story about a young lady who 7 years ago, she was 49, and she was told that she had end-stage kidney disease. And so before she received her diagnosis, she was healthy, she was living a really good life. She had a degree in sociology and she was working. She had a thriving career as a healthcare administrator. She had access to healthcare and a supportive family. Yet what her PCP told her was that you need a kidney transplant, but you may never be healthy enough to receive one. After her this diagnosis, or whatever her primary care physician told her, she started advocating and researching for whatever she could on kidney transplant. She found out that on average, people wait 5 to 7 years and they do not survive, or they usually die within 5 years of dialysis. However, while she was able to receive her kidney transplant in about 3 years, there are still people who are waiting for transplant, for kidney transplants or transplants 7 years later, and there are many others who have died. And so what are the factors that determine whether or not an individual receives a kidney transplant? Usually that is determined by race or social determinants of health. And social determinants of health can be anything from where a person lives, where they work, what they age, where they worship. And so as we could see from this diagram, that the Black race, if you're older, if you have lower income, if you have public insurance, and if you have more comorbidities, those are factors that could impact whether or not you receive a kidney transplant or any form of organ transplantation. And so we're always advocating for health equity on the show. And this is the ability for everyone to have fair and just opportunity to be as healthy as possible, no matter their social position. As I mentioned earlier, multiple factors such as age, race, gender, citizenship can impact waitlist candidates' ability to receive a transplant. For example, research has shown that heart transplant recipient outcomes differ when a recipient has private compared to public health insurance. And so what happened is an organization by the name of the Organ Procurement and Transplantation Network Data Dashboard, they monitor equity in access and transplant for an access to transplant score on ATS. The ATS summarizes into a single number an active candidate's relative likelihood of receiving a deceased donor transplant. A lower spread of ATS scores mean that there are fewer differences among waitlist candidates and in turn less disparity. A higher spread of ATS scores mean that there are more differences in ATS scores across waitlist candidates and in turn for more disparity. And so they found the ATS scores for kidney transplants. And so as you could see from this graph, disparities in access to deceased donor kidney transplants among candidates on the waitlist decreased substantially after the implementation of the Kidney Allocation System, or CAS, in 2014. And the overall kidney ATS standard deviation declined from approximately 1.64 to 1.21 during this time. And so we could also see that there's also variations between heart transplants. In a recent study on disparities in heart transplants, researchers looked at people waiting for the first heart transplant between 2005 and 2016. Of the 46,801 patients, about 67% were white, 22% were African American, and 8% were Hispanic. Over the study period, the proportion of Black and Hispanic patients listed for transplant increased. That is 21.7% to 28.2% and 7.7% to 9% respectively for Black and Hispanic patients, while white patients decreased from 70.6% to 66.5%. And we could see that in 2016, the disparity, it became less pronounced over years. For example, in 2016, the median wait time was 10.1 months for African-American patients, 8 months for white patients, and 7.4 months for Hispanic patients. However, in 2014, that was not the case. It was 19.8 months compared with 12 months for white patients and 12.3 months for Hispanic patients. And so what is the disparities in New York City? As we could see from this diagram, in 2016, the average waiting number of persons was 3,467 for white patients and 3,441 for Black patients. However, a recent study shows that there was a retrospective study utilizing the United Network for Organ Sharing database, and so the increase includes all adult patients listed for renal transplant between January 2015 and September 2019 at the 5 major transplant centers in New York City. Patients were classified as by race as white, Black, and Hispanic or other. And out of the 7,541 patients listed for renal transplant, 33% received a transplant. Of the transplanted patients, a disproportionate amount went to white, that's 43%, compared to Black, 26%, Hispanic, 30%, and other, 27%. White patients were also more likely to receive a living donor, that's 79%, compared to Black patients, which is 43%, and Hispanic 50%, and other 50%. The referral gap was significantly shorter for white patients, which is 277 days, compared to Black patients, which is 730 days, Hispanic patients, 514 days, and other 414 days. So we could see from this table that racial disparities persist in New York City, particularly in respect to access to a transplant center. Racial minorities are disadvantaged in access to living donation and tend to spend longer time on the wait list. And so efforts should be made to mitigate these disparities. And so joining us tonight is Dr. Momenti, who actually did a study recently to see what sort of interventions can be implemented to give individuals access to information about donors. So in New York State, I'm not sure if many of you know this, but it is one of the most racially diverse regions in the US, and it has the lowest organ donation rate in the country. That's 46% compared to the national average of 54%. Therefore, it is imperative that we test specific interventions among racially diverse populations to determine what methods will improve organ donation registration and understanding the barriers to organ donation, particularly for racial and ethnic minorities. And so in this study, what the researchers did was that they had participants into two groups where they showed them an educational video. In the first group, they gave the participants the survey to fill out and then the educational video. And in the second group, they gave them the educational video first and then the survey. And they found that there was a significant difference in people's intentions to donate an organ when they saw the video before they filled out the survey. And so what this tells us is that we need to continue educating the public on the importance of organ donation and transplantation. And so why is it important for you to become a donor? Because one donor can save up to 8 lives. And while transplants are up, there is still a great need for them. 20 people die every day while awaiting transplants, and more than 114,000 people on the transplant waiting list. Every 10 minutes, a new person is added to the national transplant list. And so joining us, first we'd like to thank Dr. Naomi Maria, the trial individuals, Jared Oliveira and Richard La Rochelle, Dr. Abra Hussein, Bernie Stevens, who is the CEO of GP Cleaners. As usual, continue to follow us on Minority Health Conversations on Twitter and Instagram. And so joining us tonight is Dr. Ernesto Momenti. He's the System Chief Division of Surgical Innovation and Pediatric Adult Renal Transplant Surgeon at Northwell Health. Also is Dr. Kevin Shah, a cardiac transplant team member and a medical director of cardiovascular intensive care unit at the University of Utah. I'd also like to share with you the stories of two individuals who are also joining us tonight. Ms. Shaniqua Brown, who is a 33-year-old registered nurse who is a renal transplant patient. She was diagnosed with systemic lupus erythematosus in 2014 and lupus nephritis in 2005, which resulted in renal failure in 2018. She received cadaveric renal transplant on the 31st of May, 2021. Also joining us is Mr. Ebert Mahon, who is a civil servant worker at the New York City Transport Authority as a maintainer for about 35 years, a part-time musician and a budding trader. He has been married for 42 years to Vivian and he resides in Queen. His journey to kidney transplantation began in early 2008 when his primary doctor detected through blood work that certain creatinine levels was over 1. Fast forward, one doctor who never educated him about what was really going on, he then became a patient of Dr. Hussein, who was recommended to him by a gastro doctor in 2015. With the assistance and care of Dr. Hussein and the care nurse Ellen, with Northwell's Healthy Transition Program, he eventually started at-home treatment in July of 2017, and in July of 2019, he transferred to NYU Lagon's transport program. He received his kidney transplant in September 13, 2019. And now I'd like to pass it off to Dr. Myers, who will be having the conversation with our esteemed panelists.
Thank you, Dr. Williams, for all that wonderful information. So I'm very excited to have these wonderful panelists this evening from here in New York, as well as all the way across the country in Utah. So I'm going to start with our transplant recipients, Ebert and Shaniqua. Why don't you tell our audience your story? What exactly happened that you ended up having to receive a renal transplant? So I'll need you to, Mr. Ebert, if you could just unmute yourself, and then Shaniqua, you can answer afterwards. Thank you.
Well, what happened, like I said, your host had stated earlier for my story, basically I was being treated for elevated levels of creatinine, which was showing I was going into basically kidney failure. I was around stage 1, stage 2, but the earlier doctor I was with at Advantage Care wasn't really giving me any education. So like the gastroenterologist I was dealing with, Dr. Banzel, was concerned. So he made the recommendation of meeting with Dr. Hussein, and I became a patient of his in 2015. And under his care, he worked with me. He was pretty honest in telling me he would try to maintain whatever kidney function I had for however long we could go. And it was in the early 2017, my numbers had decreased to the point that he said it was time for me to begin home treatment as far as home dialysis. And immediately from the start, even before we got to that point, he said I was a good candidate based on my physical history in the back, being relatively healthy otherwise, that I would be a good candidate for peritoneal dialysis. And at that point, that's when I began that.
Shaniqua?
My story started actually in 2004. I was diagnosed with lupus actually as a teenager. 2005, I was diagnosed with lupus nephritis after having my first kidney biopsy done. So it was kind of a slow progression to end-stage renal disease between 2005 and I would say about 2016 or so. I was pretty stable. In 2017, everything kind of just like went spiral downward. I was actually with another physicians group altogether before going to Dr. Hussein. After my 5th kidney biopsy, my nephrologist at the time just kind of said, oh, well, you need a kidney transplant, and kind of left me there. I was functioning probably at about 20% then. And I was actually referred to Dr. Hussein through a friend of mine's mother that worked with him at Northwell. So I went to Dr. Hussein 2017, still not quite on dialysis. 2018 is when I actually had to go on to dialysis, and we kind of went from there. He told me the steps to take as far as getting listed, which hospitals to go to, and from 2018 to 21, we kind of went through 2 different types of dialysis. I started hemo, then went to peritoneal, and then eventually transplanted this year.
And just could either Shaniqua or Ebert tell us the difference? Because I think our audience may not know the difference. Obviously, for us as physicians, know the difference between peritoneal and hemodialysis?
Hemodialysis is basically filtration directly through the blood. So you have needles that goes into your arm. You're usually in the center 3 times a week, and it pulls the blood out, filters it, and puts it back in to your body. With peritoneal, everything goes through the abdomen or the stomach. It's a lot easier on the body, and it's a catheter. There's no blood involved. It's kind of liquid solutions that goes into your abdomen, filters through the abdomen, and it's done like that.
So instead of going to the bathroom as people normally would, the dialysis is cleaning your blood or your urine for you, so to speak, because you guys don't make urine after a certain point, correct?
With most patients, I actually never stopped making urine, but with most patients, yes, after a while you do stop.
Okay, thank you for clarifying that. Okay, so you both started dialysis and then you were put on the list for a transplant. So I'll start with you, Ebert. Can you explain what that means for our audience when you get on the list and what you have to do to get listed?
Well, basically what happened when you go to a particular hospital, you submit your application like I did through Northwell, and then Northwell basically would do a pre-screening where they want you to provide them with all of your medical records and your medical history. And then at that point, they'll review your medical history, and then they'll make an appointment. And I had the pleasure of meeting Dr. Ernesto. You would come in and you go through like a whole battery of tests. It was 8 hours where you would go there to meet with the entire team. It was like a marathon. And I believe the day I went to Northwell, I was there from like 8 in the morning till about 3 in the afternoon. and I met the entire team, from everybody from the nurses all the way to Dr. Ernesto as well. And basically they would explain to you all of the steps of what it would mean to be transplanted, and everything I would have to do as a patient to maintain my health. So I maintain a certain level of health to make sure that you're qualified to be transplanted. Because I believe they basically want to know that if you get transplanted, that you will maintain it for a good period of time and try to reduce the chances of any possible rejection. So it was just a lot of education crammed in 8 hours. And I know by the end of the day, when I went home, my head was spinning to try to take it all in. And likewise with my wife, who was with me. But that's the main thing. You really have to get pre-qualified to make sure you're at a certain level of health so that the transplant, when it does come around, is successful. And then every year you would meet with the entire team to make sure that this level of benchmark of health is maintained so that you're still a candidate to be transplanted.
And were there other teams that you had to meet with, or was it just Dr. Ernesto's team?
Well, I met with him, and like my other friend here had described earlier, he basically encouraged me to go to other hospitals to get placed on the list, because he figured that the more hospitals you can get placed on the list, the better your chances are. And I was also blessed that I had 2 coworkers at Transit who was both transplant patients as well. So they kind of walked me through their experiences and kind of coached me as far as what I should do, what I should have ready in terms of my medical records, and simply reaching around. So not only was I listed with Northwell, Dr. Hussein encouraged me to travel to Tampa Hospital in Tampa, Florida, which I did go down to in December of 2017, and I got listed there. And then also I was looking elsewhere, maybe up at Mount Sinai. And then finally, by the middle of June of 2019, when I was going for follow-up work at my dialysis center, where I met my nurses every couple of weeks, I met with someone from NYU Langone, and they were looking for a lot of candidates. So again, I went through the whole process and got placed in their list. And eventually, after I was seen in July of 2019, I wound up getting transplanted just about a month and a half later, in the middle of September of 2019.
Wow, that's pretty quick. And so to return it to you, Ernesto, can you explain how someone should seek out a transplant team? Ebert was mentioning that he came to you and you actually recommended that he go to a couple other places. His nephrologist, the esteemed Dr. Hussein, also recommended. So how would you recommend that someone who is at the point like Shanika and Ebert were not too long ago of dialysis, and they're saying, I want to get a transplant, how should they go about looking for a transplant team?
Well, Alison, thank you very much. Ever great to see you as always. Basically, transplantation has 4 major components, which means referral, evaluation, transplantation, and post-transplantation periods. It is our belief that every person who has kidney problems should be considered a transplant candidate until proven otherwise. We should give a chance to everybody, and everybody should be referred for transplantation evaluation. Once you're referred for transplantation evaluation, we do a very thorough examination of all the organ systems, including the heart. Let's keep in mind that 90% of all transplant candidates have high blood pressure and 50% have diabetes, which are systemic afflictions that not only affect the kidneys, but they affect the heart and other systems. So we need to make sure that the heart can tolerate the surgery and the immunosuppression as well. So we evaluate them, and then once they qualify, we list them for transplantation. If for whatever reason they don't qualify, we try to solve whatever prevents them from qualifying, such as performing a revascularization of the heart, putting stents, or doing a cardiac bypass. So unfortunately, though, a wait time, that is the time we have to wait until a cadaver organ, a deceased donor organ, becomes available, varies nationwide. That's why we always encourage all transplant candidates to seek to be listed at other locations. For example, Everett mentioned Florida. The wait list in Florida is shorter than in New York. New York and California have the longest wait times for the whole country. It's 5 to 8 years. And when we say this, let's keep in mind that the mortality rate on dialysis is about 50 to 6% by 5 years. So we have to avoid dialysis at all costs. Ideally, all individuals should be transplanted before they start dialysis or soon thereafter, either with a deceased donor or ideally a live donor. Live donors work a bit better than deceased donors in the overall spectrum. The other factor that we have to concentrate here is the fact that why there are disparities in the wait times nationwide. And that's associated, as Maya very well mentioned earlier, by the amount of people who are willing to donate, who sign their registration cards, their driver's license, or other type of registries. And unfortunately, among the 50 states of the US, New York has the lowest donation and the lowest registration rates. To give you an idea, nationwide, there's approximately 55 to 60% donor at a 55 to 60% donor registration rate. The highest one, such as in Montana and Alaska, is in the high 90s, 95 to 96%. New York, for the state of New York, the donor registration rate is approximately 35%, with some places within New York City going as low as 25 to 5%. So that's something that we need to address, because we need to, within transplantation, we have to look at several factors that should guide our policies, which include equity, social justice, participation, efficiency, effectiveness, acceptability, affordability, and accessibility, which is a major point with referral to transplant centers. As Everett and Shaniqua mentioned, we need to make sure that everybody gets referred. We need to make sure that everybody's told there's a chance that you will need a kidney transplant. We should start to plan on this. We should optimize your kidney function, but we should make alternative plans, such as planning to receive a kidney transplant. Let your family members know, let your friends know. You'll be surprised how many people volunteer to be a live donor through social media. We always encourage all our recipients to announce it through social media, through their social events, religious events, and to ask other friends to mention it. Over the past months, we've done multiple live donors who met through social media. They did not meet even personally initially. These individuals volunteered to give a kidney. But let's keep in mind, for somebody to offer to give a kidney, they need to be aware that they can do so. So it's our responsibility to let them know that we need help, and there's nothing wrong with accepting the help. And it's so beautiful afterwards to say, thank you for what you did for me. And they become lifelong friends.
Yes, that's true. That's wonderful. And I think most people in our audience are very familiar with this renal transplant, but I don't think most people are aware of the fact that you can also have a cardiac transplant or a transplantation of your heart. So it's obvious how you can donate a kidney, but how do you donate a heart, and who needs a heart transplant? Kevin, can you please help us understand that?
Sure. Thanks for the question. Heart transplantation is very similar to kidney transplantation. There's a large number of people on a waiting list every year, and there's a small number of patients that are the unfortunate few that are successful enough to go through a heart transplant. So there's about 5,000 heart transplants performed every year worldwide, and that number has been pretty much the same roughly every year. Patients that in the US that often need a heart transplant, they tend to be patients who develop a weak or a stiff heart to the point where they're having frequent symptoms or they're frequently hospitalized because of their heart. And similar to kidney transplantation, there are heart transplant centers. There's about 300 heart transplant centers in the United States that have comprehensive teams that they can work with a patient. Oftentimes a patient is referred by a general cardiologist to a heart transplant or a heart failure cardiology expert. And from there, if a team feels that someone is a potential candidate, it usually comes down to three things, which is your heart is sick enough for which if you had a new heart, you would derive benefit from it. The rest of you is well enough to undergo a heart transplant. So that means your kidney, your liver, your lungs, they're strong enough to undergo not just the major surgery, but everything after the surgery. And then lastly, the rest of you as a human being. So from a psychosocial standpoint, from a financial standpoint, from an insurance and access standpoint, does undergoing something like a heart transplant, is that a viable option for someone? And that's really where a lot of the disparities do lie, particularly within the minority communities. But that being said, one can offer to be a heart transplant donor. Obviously, that's a one-way street. And oftentimes, the heart donors are patients who unfortunately either have they're in accidents, or oftentimes it's due to substance abuse overdoses. But more often than not, those patients, their hearts are fine. And those are the hearts that are often allocated to people that are waiting on a heart transplant list.
Yeah, we actually have both at our center. We have both Ernesto's team with the renal, but we also have a cardiac. In fact, there's a patient that we just took care of, and he had been in the hospital for almost 2 months, and he finally got his transplant last week. So sometimes, I don't know if you guys agree with this, but I know one of my patients told me that for him, July 4th and Labor Day were the most likely weekends that he was probably, unfortunately, due to drunk driving and things like such as that nature. Those are usually the big times. So we definitely have seen several transplants recently. And I don't know if that's the same that you've seen, Kevin and Ernesto.
Yeah, there tends to be oftentimes an uptick in the number of potential heart donors around holidays in general, and around kind of inclement weather as well, because a lot of the accidents tend to happen, whether they're motor vehicle accidents or, like you alluded to, maybe overdoing on something and getting it in. And oftentimes those patients, their hearts are just fine.
Ernesto, have you noticed the same thing with your kidney transplant patients?
Yes, unfortunately, there are several predisposing events that may lead to individuals becoming involved in tragic accidents. However, irrespective of the cause, we thank all those who donated and whose families made the decision to donate, and their loved ones first keep on living through the recipients. And it's such a beautiful event to be able to see when a donor family meets the recipient, how grateful they are, and many times they become lifelong friends. And it's so beautiful. So thank you to all the donors, and the donor families. You've made a whole difference in the world, and you allowed many people to keep on living.
So speaking of donors, that leads us to our next question. So there's two types of donors. You either have a living donor or a cadaver donor. So in the case of the cardiac transplant, we simply will have cadaver donors because you only have one heart, so we can never have a living donor. Whereas our kidneys, we have a pair, we have two. So you actually can have, if somebody has two kidneys, they could be a living donor. So Shanika and Ebert, you both mentioned the fact that you received cadaver donor or cadaveric donor. Did you try to get a living donor? Was there anyone that got tested in your friend or family network before you proceeded with a cadaver donor?
I did have some family get tested before going to a cadaver donor, and ironically, every single person in my family that tested was not a match. And my family were not too inclined to do the paired exchange, so it just kind of left me with the only route as having a cadaver donor.
And well, for myself, I was talking to people. I'm a longtime member in my church, over 25 plus years. And I was going to approach members in my church about putting it out there, but I kept shying away from it. And it so happened the way it worked out when I went over to NYU Langone, that basically kind of like ended my search, because at the time they were implementing a program in 2019, excuse me, where they were aggressively looking for people to come on, because they were trying to do what they can to make use of whatever particular cadaver donate kidneys that they were coming across. and that's how I ended up getting mine. So I was gonna go to family and friends, but I shied away from it, and it just so happened it worked out where I wound up getting a cadaver donor.
Alison, let me make a point here for all those interested in donation. I mean, let's suppose that I want to donate to somebody. Already in that way, we take out any, we make it totally, I mean, up to the point. Before, when I volunteer to donate, I have to express my desire to donate first. I mean, I have to call the transplant center. So in that way, there doesn't seem to be any effect as if they're trained for me to donate. I mean, once I call, they call me back. The person undergoes a very thorough evaluation, including through social work, eventually a psychological, psychiatric evaluation. There's nothing wrong with them mentally, but we do that to make sure that they're really volunteer and they're willing to do it. And once it's determined that the person, it's safe for the person to live with one kidney to be able to donate, only at that time they're approved to donate. If for whatever reason it's been thought that the person would not be safe donating, or it's that there are other type of problems, they would not be allowed to donate, irrespective of how much they want to donate. So suppose that we're at that stage, and suppose that I was going to give a kidney today. Now, let's go for the worst case scenario, which is what usually most of us tend to address at this point. Though my risk of, suppose I was going to donate today, my risk of dying in the surgery is 0.03%. It's minimal, like in any surgery. And my risk of developing kidney failure 20 years from now, that is by September 9th of 2041, 20 years from now, overall would be 0.5%. So please never be afraid to let people help you. They'll be evaluated, they'll be given all the risks and benefits, and the potential for complications is very small. And in the worst case scenario that somebody develops kidney failure after donating, they would go to the top of the list to receive a deceased donor. So, I mean, everything has been addressed, and there's nothing wrong with accepting a kidney from somebody else.
Okay. Thank you for that explanation. I know that one of the liver transplant folks had reached out to me. There was a patient who, I'm sorry, actually it was renal. And he had reached, no, it was liver, I'm sorry. And he had reached out to ask about if somebody with pre-diabetes would be a good donor. So I was just wondering your thoughts on, because obviously there's a lot of diabetes in the Black and Hispanic communities. So what are your thoughts, Kevin and Ernesto, if someone had pre-existing diabetes, about receiving an organ from them?
Yeah,
Kevin, go ahead.
Sure. From the heart perspective, severe uncontrolled diabetes that's poorly controlled can be a contraindication or a reason to not be a potential recipient for a heart. Oftentimes, it's something that can be managed with medications, with insulin, with lifestyle changes. That being said, if diabetes has gotten to the point where it's causing sort of end organ dysfunction, causing kidney failure, causing other problems, the challenge with undergoing a heart transplant is after transplantation, people usually don't do very well if their diabetes is poorly controlled beforehand. So usually it's something that can be modified over time, and then someone can potentially become a candidate if it's poorly controlled initially.
From my point of view, diabetes accounts for 50% of our cases of kidney failure. So half of our recipients are diabetic. So diabetes is not a contraindication to receive a kidney. However, it's a contraindication to be a donor. We usually don't accept donors with diabetes. But I think that the best person to answer this question is you, Alison. You're the diabetic expert. I'm not going to voice too much here. All right, I'll let you speak.
Yeah, so usually we would not recommend it. In this particular case, this person actually, the donor had pre-diabetes. It was like they were just on the cusp. And so we looked it up and we just realized it probably wasn't the best idea because that person's risk of actually developing diabetes years later, going to your point, Ernesto, was going to be probably fairly high. So then they probably would need a kidney later themselves. So they actually, and if, otherwise they were like a really good match. So that's what also made it so unfortunate. And it would have been a living donor match, but we actually said no. So it was unfortunate, but it was a really good match from a serological standpoint, antigens and whatnot. But yeah, so thank you for that. Okay.
Correct. We always need to make sure that the live donor it's safe and that they can continue to have a normal life. So they can, if that's the case, then they can help the person with renal failure. Otherwise, I mean, we prefer for them to be safe, and we'll find somebody else for the person.
Right, right. So I just want to go back to this question about disparities. You know, we were talking about this united network of organ sharing and how they've really been trying to work on equaling the playing field. So more people that look like Eber and Shaniqua are getting these transplants because, as Maya showed earlier, there's definitely discrepancies between people of color getting transplant and people who are Caucasian. So in a recent paper, this is for you, Kevin, by Chuari et al., they noted that even though there have been changes in terms of increases of Blacks and Hispanics receiving transplants, that there is an increased amount of mortality or death in Black patients and who are in the post-transplant period. And so why are we having such poor outcomes? We're doing a better job of getting these people transplanted, but why are they dying? Shouldn't the transplant be helping?
You know, it's a really good question. I agree. It's been an issue that's slowly improved over time, but it's far from pure equity at this point. You know, there are some biologic reasons for this, particularly within those of African-American descent. There are data to support that they have higher percentages of preformed antibodies against potential antigens. In other words, some would describe them as more sensitized, some patients, in which if they were to receive a heart transplant, there's a higher percentage likelihood of potentially rejecting that heart over time. That's probably at play in a small percentage of the cases. I don't believe that's the main reason why these findings exist. And again, that data is really specifically within the African-American patient population. So it wouldn't explain a lot of the other minority disparities. A lot of the issues that come up after transplantation, after you have a heart transplant, for example, the amount of surveillance and testing that you undergo, particularly in the first year, is extremely rigorous. You have very frequent clinical visits, laboratory checks, and for the heart, we do very frequent surveillance biopsies. So we like to say we give you a new heart, but then we take a little piece back every few weeks. And the reason is a lot of times you can have rejection of your transplanted heart and you don't feel any symptoms whatsoever. And so being able to make all of those visits, again, from an access standpoint, from an insurance standpoint, from frankly a day-to-day life standpoint, is not easy for a lot of our patients. And so we ask them to jump through these giant hoops after they have a heart transplant for surveillance to make sure that their heart does well. But frankly, it's not easy for all patients to make all of these visits. And so beyond the biologic reasons, there truly are just access issues, affordability issues, and issues from a day-to-day practicality standpoint of trying to make all these visits.
All right, and we see some of the same disparities as well in our kidney transplant patients, in which there's a paper that recently came out by Ng et al. That noted that Black patients are less likely to be listed, even though we have seen these improvements in hearts as well as kidneys. So Ernesto, can you speak on that?
Yeah, Allison, we have a major societal problem that needs to be addressed and needs to be addressed urgently. As you mentioned, Black candidates have a 25%, it's a huge number, 25% less likelihood of being listed than whites. And we need to solve these problems. I mean, even racial disparities in the kidney transplant waitlisting persisted even after adjusting for medical factors and social determinants of health, which makes it we need to address this thoroughly We need funding to address this and to stop this inequality that cannot persist. We need to move as a society with the help of the government and of multiple organizations to put an end to this disparity, because people are dying, and that needs to be stopped. Indeed, our goal should be to prevent any death of anybody who's waiting for a kidney. We should eliminate the wait list, and everybody should be able to have access to a kidney. That should be our main goal. I mean, we have to eliminate the wait list. And this is unfair, and it's up to us to be able to do it. It's individuals who make a difference. So we need to get together and create this new system where we have no wait list and everybody gets a transplant before even starting dialysis. Dialysis is a friend, but not a very good friend. It takes a very huge toll on people. So we cannot limit ourselves to accept all these disparities, and we need to do something to break them apart and to eliminate them completely.
So I will turn the question over to Eber and Shaniqua. What would you recommend? Now, Shaniqua, you work as a nurse, so I'm sure you probably see some of these issues with inequality and equity.
I would say recommend, I think education, yes, we're educated a lot when it comes to transplant, but I think certain people in certain ethnic backgrounds, I think need more education, but the access to resources after the fact. Medications are very, very, very expensive. So I think it's a combination of education, but our access to resources. And I think that's what makes it so much of an issue with the disparities, because not everybody has access to the same resources. And it makes it very difficult.
I definitely second that, because for myself, I'm seeing that Shaniqua is a nurse, me being just, coming as a patient, like I expressed in my story, when I was diagnosed in early 2008 with my creatinine going up until early 2015, when I switched over from the original nephrologist. He didn't teach me a thing. He didn't even make me aware as to how serious a condition I was undergoing. I would see him every quarter of each year, and he had me undergo some basic lab tests to see where my creatinine level was at. He said, "Oh, well, there's no change in your creatinine, so just keep doing what you're doing, and we'll test you in like 3 months." And the one time my wife came with me, she immediately expressed her displeasure with him because he wasn't educating me. He didn't give me any literature. He didn't give me any books, not a thing. But when I first met with Dr. Hussein basically told me, "Look, you're coming to me late in the game. I'm going to do what I can working with you to keep you as healthy as possible with your kidney function. But you have to agree that when it's time for you to begin dialysis, we'll start it." I said, "No problem." And then after he told me that, he gave me a book on what I was dealing with kidney disease, which I still have. So he was the first one really educating me from day one, whereas the other doctor failed to do that for several years. And I would be remiss to tell you guys, I was very angry at that when I found out, because if I knew early on what I was dealing with in the early stages of my kidney failure, I could have done a lot more in terms of changing diet and the like to try to extend the life of my kidney function that much longer. But once I came to that point, I was just grateful that Dr. Hussein immediately made it a point of educating me. And then, like I said, he immediately got me into that program with Northwell, which I'm forever grateful, called Healthy Transitions. And the nurse, Ellen, who was the lead nurse who always saw me, she was one of I call all my nurses coaches. And she was my first rock star, really teaching me how to transition into what it is to really dealing with kidney failure and dealing with kidney disease and the possibility of going on dialysis. So she really got me able to wrap my head around it and to be able to move forward positively with whatever the challenges were. So I'm forever grateful for what she was able to do. But I echo Ms. Aniqua's first point. Education is the key. So I try to educate people, learn what you can do, and I try to share my experiences about the potential best course, which, like I said, if you have to do home treatment, peritoneal all the way, keep educating yourself, be an advocate for yourself, continue to ask questions. Don't be left in the dark.
Mhm. And what would you say, we'll start with you, Shaniqua, and then Ebert, you can follow up. For people who are on dialysis, who are hesitant about getting a transplant in our communities of color, what would be a piece of advice that you would give?
I would say first, always do your research. Make sure you know what you're going into, both pros and cons. But I think it's also very beneficial to take into consideration what your doctors tell you, because they're essentially the experts in the area. And some people are hesitant because they don't want somebody else's organ, but I think listening to the doctors is definitely probably number one, because transplant, in my opinion, is definitely a better quality of life. So definitely listen, do your research and listen. That's basically it.
I definitely echo what Uniqua said. And I think for me early on, like these statistics that was named earlier about the possibility of someone becoming transplanted, I realized early, part of it for me that I think I was kind of blessed that once I realized what the numbers were and transitioning to peritoneal, I took a long, hard look and I dealt with the reality that there could be a possibility I would never be transplanted. So with that, I positively moved forward with, look, if I'm going to do peritoneal, I'm going to do it to the best of my ability, keeping myself as healthy as possible while maintaining as positive a state of mind as possible, because I immediately started going to other resources that deal with kidney patients and kidney transplants and reading successful stories of other people who successfully who are living 20, 30 plus years while on dialysis. I said, well, if there's a possibility I won't be transplanted, I'm going to be basically modeling myself after these stories that I'm reading here, and I'm going to move forward with everything I can to do what I can to keep myself as healthy as possible while treating myself at home. So
that's a good point. And I think it's really important about numbers. I had a patient today who her friends were like, why didn't your doctor tell you your kidney function was at 30%? And I had explained to her, well, when you came to me, you were at 50%. So when you go from 50 to 40, and then after you have one of your kidneys removed down to 30, you know, it sounds like it might be a big, but it really isn't. I said, we did everything to optimize you. Your kidney disease came from something else. It wasn't from your diabetes. You were optimized. And because you lost one of your kidneys, that dropped your function even further. And usually the nephrologist is not really going to see you until you get down below 30%. Usually they're not seeing you when you're 60, 70%, because it doesn't usually happen overnight that you go from 60 to 20. And I think a lot of people don't realize that. They think that, oh no, once I get to this point, I'm automatically going on dialysis. But I'm sure both you, Ebert and Shaniqua, it took some time before you got to the point of dialysis. You probably sat 20, 30% for some time before Dr. Hussein said, okay, now it's time to start dialysis. And I think a lot of people don't realize that it can take years. It doesn't usually just happen overnight that you drop to 15% and you go on dialysis, unless it's something really bad acutely happens. For most people, it takes quite a while before you even get to that point. And then last but not least, another part of our hesitancy in our community is around the vaccine for COVID. And as mentioned earlier, they are now recommending that people who have had a solid organ transplant receive a booster. So Kevin, can you just explain your thoughts on that, on the food booster?
Sure. So as you mentioned, once you have a solid organ transplant, whether it's a kidney transplant or heart transplant, you take immunosuppression. Right? You take medications to suppress your immune system to prevent rejection of someone else's organ that's in your body. And they've done enough studies on transplant recipients, a few elegant studies from Johns Hopkins, in which they studied patients who had kidney transplants, and they're measuring the degree of antibodies that they've developed after they were vaccinated. and the titers or the amount of antibodies that they have, so the degree of protection that they may have from COVID-19 was really across the board. In other words, some patients had a high degree of immunity and some patients had a low degree of immunity. Based on that and some other data, there's strong recommendations that if you've had an organ transplant, and we're recommending the same for our heart transplant recipients that already have a heart transplant, or patients that are undergoing the process of being a heart transplant candidate, we do recommend that they're not just vaccinated against COVID-19, but that they receive a booster dose as well, because we know that, like I said earlier, if they're going to be taking immunosuppression and they don't have the same degree of immunity as someone who's immunocompetent or doesn't have an organ transplant, we want them to be protected from this virus at all costs.
I will turn it over to Dr. Williams. We have a question from Facebook.
Thank you. And the question from Facebook is, how long is the wait between finding a donor and the actual transplant date? Is there a standard time frame or is it case by case?
Probably for kidney is my guess in that. Ernesto, any comments?
Yeah, I mean, if you have a live donor, we can, the time it takes to proceed with a transplant is the time it takes for both the donor and the recipient to complete other testing. If they do it quickly, could take, 2 weeks or less or a bit more. Depends how quickly they proceed with all the testing. It's an individual dependent factor. So could go very fast.
And for heart, for what it's worth, if what is listed for a heart and a suitable donor heart becomes available, usually a transplant happens within a day or two. And sometimes it's the logistics of the geography. In other words, the recipient may be here, the donor heart may be here, and then the center may be here. So it's just getting everyone in the same place and undergoing the surgery.
And by the way, let me clarify one thing for kidney transplants. We also highly recommend the booster dose. As Kevin mentioned, after one dose of vaccine, only 20% of kidney transplant recipients have antibodies. After 2 doses, it's 40%. After 3 doses, it's 60%. So, we highly recommend that all those transplant recipients who receive the vaccine get antibody levels. Please keep in mind, getting the vaccine doesn't mean you will get antibody levels. Furthermore, let me speculate one more thing. You may need a 4th dose maybe. So, we always have to aim to be safe and to do what's the best thing to protect us. So please get tested for antibodies to make sure you have antibodies, and keep in mind they may decrease over time. So we need to keep an eye on that. The last word is not said here.
Thank you very much. And I actually did see that statistic, but I wasn't too sure if it was for or against getting the vaccine. So I was just like, I'm not the expert here, so I'm not going to include it into the PowerPoint that Dr. Allison originally did. But we've come to the end.
I hope I'm not the expert either, but I hope I answered your question.
Yes, you did. You did answer the question. And I do like that you said the thing about the vaccine, because I believe that immunocompromised individuals, it's like the immune system is not as strong as other individuals, so they may need the vaccine. And so we have to try and let people know that there's nothing wrong with the vaccine. In terms of the vaccine, it doesn't work. It's just that immunocompromised people need that additional boost to continue, like those who are, fully healthy.
So furthermore, when somebody who has received an organ transplant and is on immunosuppression tests positive for COVID, that the PCR is positive, they should immediately call the transplant center, because they will require potentially antibody treatments. So please, as soon as somebody tests positive for COVID, please call your transplant center to notify us, and we'll help you from there on.
Oh, I have a quick question in reference to that I just thought about for Kevin and Ernesto, if you don't mind. I know for our patients who are on chronic steroids, we tell them to double up. People who don't make steroids on their own, we tell them to double up on the day of their vaccine. Do you also recommend that for your transplant patients, that they should double their dose of prednisone the day that they get their vaccine?
We have not been, but that's not a bad idea. We haven't been doing that though.
Yeah, I agree. I mean, no, we don't, but it's a good idea. It doesn't hurt. So, I mean, why not, Allison? I like your idea.
All right. And as usual, it's the hour. There's so much information in the hour and it goes by so quickly. So now it's the time to wrap up. So as Dr. Momenti or Ernesto mentioned, that there are 4 major things that individuals have to go through when receiving transplants. That's first the referral, then the evaluation, then the transplant, and then the post evaluation for the transplant. And usually we have 90% of all individuals who receive the transplant will have high blood pressure and 50% will have diabetes. While we do have a number of disparities, one of the reasons for that is because it's about access, and transplant victim or transplant people who have received organs, they usually have to go through a lot of post evaluations, and sometimes it's after they're already sick. It's going to be very taxing to the body, and they might not necessarily complete these tests that they have to go to, but it's very, very important that they do go through this test. As Shaniqua and Mr. M. Ebert mentioned, that it's not all about the education, but in addition to this is the access to resources. The medications are very expensive, so if we could get a lot of programs that would compensate or lessen the cost of these medications, then that would be helpful to the individuals who are actually receiving organ donations. And as Dr. Momenti or Ernesto mentioned, that we need more funding to be able to understand what's going on, what are those disparities, and to be able to study more about transplantation and what we could do to improve access to individuals. In order for you to get a heart transplant, there are 3 things that you need to go through. One is the heart is sick, and will it be able to take the transplant? Is the heart well enough to undergo the transplant? And what's about the individual? Will they be able to sustain getting the transplant? And irrespective of what individuals think, the risk of dying from transplantation is very, very low. It's like any other surgery, it's 0.03%. You can donate a liver to individuals, but most likely you're not able to donate a heart because we need our hearts to survive. And so please, 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 if you are a donor, you could save 8 lives by donating or going on the donor list. You could do that when you go to the DMV. You could find out more information. I don't know if Kevin or Ernesto want to tell individuals where they could get more information if they would like to become a donor. But as mentioned earlier, the disparities do exist because there are not a number of people who know about donations or what it is to donate. They're skeptical about donating, but it is okay and it is safe for you to be an organ donor.
Well, Maya, thank you. Let me make the answer the question. Call us at Northwell and we'll help you with everything. And my second point is, wouldn't it be nice if we made transplantation the first medical group where we eliminate all the biases for color, ethnicity, religion, and make it we're all together fighting for one cause and we all can help each other. Let me propose that as a challenge.
Yes, indeed. And could you just tell individuals where they could go ahead if they want to donate, be an organ donor, where it is that they could get more information on that?
Correct. They can go to the, as I mentioned, to Northwell. Correct. Absolutely. And there are other centers. Live on New York, which is the organ procurement organization for in New York, or I mean, each hospital has their own sites as well. I mean, all the centers are very good. And basically through the DMV, and we're doing some new studies where we're trying to identify new sites where people could register. I'll keep you updated. We'll have several publications coming out. I don't have the final results yet.
Thank you. So as usual, thank you so much for everyone for joining us. Our next COVID-19 conversations will be on the 23rd, and we will be discussing the COVID-19, the COVID vaccine, research around COVID, and vaccine hesitancy, as well as access in the Black and Brown communities. Continue to stay safe and remember to wear your mask. We're still in the middle of a pandemic. See you guys on the 23rd.